So again, perioperative pearls, if a patient's on an extended release opioid, I recommend you continue it perioperatively without change. That includes the morning of surgery with a sip of water if it's okay with your anesthesiologist. The importance of this can't be understated. So if a patient's on a chronic dose of morphine extended release, it's like a basal on a PCA. They constantly have a certain level of morphine in their system. And if they go through the stress of a surgery with postoperative pain and you've taken away that baseline dose, you're already behind the eight ball, right? You've taken away what keeps them functional without increased pain, and then you're causing pain on top of it. So I really recommend continuing the extended release opioids perioperatively. If it's acceptable from your standpoint, use regional anesthesia to help you. And if available in your institutions, ketamine can be a really useful adjuvant for patients on chronic high-dose opioids who have really tough to control postoperative pain. That's a whole talk in and of itself. I've given you a citation in the references that looks at the consensus guidelines on how to use ketamine postoperatively. There were some consensus guidelines just on general postoperative management of pain that was released in 2016 from a bunch of the pain and anesthesia societies. It's 32 recommendations. We're not going to go through all of them, but I'm going to talk some of the key. They recommend using oral opioids over IV whenever you can use orals. There's no evidence that the IVs work any better, and you're going to have a much easier time, especially upon discharge, converting them if you're using orals. And they recommend avoiding IM doses. The pain of those injections is not insignificant, and really the absorption of those drugs is unpredictable. If you're using an IV, they recommend PCA over just having the nurses administer doses. And they recommend avoiding basal infusions with any IV PCA in an opioid-naive patient. If it's acceptable from a surgical standpoint, you should really consider supplementing with NSAIDs and even Tylenol in addition. And you should consider giving a preoperative dose of celecoxib. Now, this one's going to be a little bit more controversial in this room because I know there's orthopedic literature that talks about fracture healing rates with NSAIDs. Now, in this consensus guidelines, their review of the literature did not show a significant enough effect on it to recommend against it. But the bottom line is you're the experts in terms of managing these patients, in terms of whether or not you can use an NSAID or not. But I would recommend you use this tool if you think it's acceptable for your patient. Considering gabapentin is really important if they're not already on it. Gabapentin can help you perioperatively. There are some suggestions that giving a preoperative dose will reduce the postoperative pain. In patients on long-term opioid therapy, as I said, do a thorough preoperative evaluation. Expect that they're going to have higher postoperative opioid requirements. Consider a consultation with pain and/or addictionology, depending on why they're on the opioids. And consider these non-opioid adjuvants and regional anesthesia if it's acceptable to you from a surgical standpoint.